Himlata, can you check now?
Yes.
We should be live.
Not working.
Not yet?
Not yet.
It's working. It's working, I think.
Yeah, it's working. Yeah, okay. Okay, Dr. Himlata, I request you to introduce the speaker.
Thank you, Sujit. I'm Dr. Hemlata. I am deeply honored to cordially welcome our speaker for today, Professor Prabhat Jha. The University Faculty Association and the UGC FRP community are very grateful for sparing time for this event. We are glad to have you today here for occasion. We have limited we are having this talk on Zoom meeting, as well as this event is being live streamed on YouTube. So viewers can watch this on YouTube as well. As we all know, our speaker today is Professor Prabhat Jha. He is a university professor at the University of Toronto, endowed professor in global health and epidemiology and Canada Research Chair at the Dalai Lama School of Public Health, and the founding director of the Center for Global Health Research at St. Michael's Hospital. Professor Jha is the lead investigator of the Million Death Study in India, which qualifies the cases of premature mortality in over 3 million homes from 1998 to current. His publications on tobacco control have enabled a global treaty now signed over by over 180 countries. He founded the Statistical Alliance for Vital Events, which focuses on reliable measurement of premature mortality worldwide. Earlier, Professor Jha served in senior roles at the World Health Organization and the World Bank. He was made an officer of the Order of Canada in 2012. Professor Jha holds an MD from the University of Manitoba and a DPhil from Oxford University, where he studied as a Rhodes Scholar. Professor Jha will be speaking on serological and mortality studies of SARS-CoV-2 infection in Canada, India, and globally. I request Professor Jha to commence his talk. But before Professor Jha begins his talk, all participants are requested to mute their microphones and turn off their video. Those participants viewing on Zoom and YouTube can type their questions in the chat box and can clearly mention the name and affiliation. Dr. Tandel will be conveying these questions to the speaker. So without any further delay, let us begin the session for which we have all been eagerly waiting for. I request Professor Jha to commence his talk.
Thank you very much to the organizers. I'm really grateful for the invitation, and I'm delighted to see this network that you formed to try to encourage STEM scholarship, and very much happy to contribute to these efforts. And it turns out the pandemic is, in some extent, a blessing in disguise, at least in terms of more broader sharing of knowledge. So I hope that these kind of online fora to share knowledge will continue. So what I'd like to do today is, here we go, give you an overview of, let me just start at the beginning. Yes, of, I'll just minimize these slides, excuse me just one second. Yeah. Of serologic and mortality evidence on SARS-CoV-2 infection in Canada and India. This is
Canada কথা বলছে লোকটা প্রভাত ঝা
sorry, someone's not got their mic muted. Please mute your mic if you're on Zoom. Okay. Right, and let me start with my conclusions. First, that in Canada, in the first viral wave, broadly from April to July of 2022, we had a reasonably low level of infection, roughly between 1.7 to 3.5% of adults, and low infection mortality rates. That translates approximately to between 500,000 to 1.1 million Canadians infected, half of whom were adults above age 20 or 18, but below age 40 years. And Ontario, my current province, was the most affected. Asymptomatic infections were about a quarter of the total, but more in the elderly. And although we had generally good news, we had quite bad news in that nursing home prevalences based on mortality were about 13 to 17%, and nursing homes accounted for 80% of all the COVID deaths in the first viral wave. The conclusions for India are very much different, that based on some new evidence that I'll show you, there is very high prevalence in the larger cities, perhaps 40 to 50% or even higher. The good news is that there seems to be clear evidence that the new infections peaked in early December and have subsequently come down, and that there's surprisingly low death rates given the levels of infection. This suggests that widespread household transmission is occurring in India. My final conclusion will be obvious that what is needed going forward are ongoing large-scale epidemiological studies. Serosurveys, mortality studies are essential to guide the response, particularly for vaccine programs. So the starting point is an extraordinary public attention to the challenges, but reasonably low levels of evidence in the public discourse. So this is the national paper in Canada, Globe and Mail, which is commenting on the large numbers of deaths. Now Canada's faced 20,000, making some criticisms about the science task force, which are actually not true, that they're not able to get national data, but also ignoring in their own publication that they actually have covered us providing national data to covering 10,000 Canadians. In India, the Financial Times has written a story called "The Pandemic Burnt Itself Out." And, I'm sorry, someone is still not on mute, if you could, because I'm afraid that's quite distracting. If you could all...
Can everybody please switch off your microphones? This is once more, we request you to please switch off your microphones, all of you.
Okay, thank you.
Sorry, Professor Jha, please continue.
Thank you. So the headline in the Financial Times is "The Pandemic Burns Itself Out in India." And I'll show you some evidence that says, well, the epidemic is very different, but not necessarily burnt out. So the big concern, of course, is that we're in various waves of the COVID pandemic. And the concern is, will we see something at all akin to what happened 1918-19, where influenza might have killed perhaps 100 million worldwide, including perhaps 20 million in India. And here you see the patterns of mortality in the UK. And there was a first peak in roughly summer of 1918, and then a very large peak in later fall and early winter of 1819 and 1819. And this is the concern. So we've seen the COVID first wave. Are we in for a second large wave? Now, the important thing to note is the scale here, that death rates, even in the first wave of the influenza, were quite high, roughly 5 per 1,000 at the peak, which translates to, in middle age, roughly a 16% chance of being killed between age 30 and 70. The top rates, or close to the peak rates, for example, in the US, are a matter of magnitude lower, about 10-fold lower. So it's very unlikely that we're going to get something as dramatic. At the peak, the death rates were such high that the risk of death was over 1 in 2. That was at the peak, and that's when the soldiers from World War I returned back to England, and that very much contributed to the large peak. So we're not in for anything like that, but we are in for certainly waves of infection. So when we go back, and this is my slide from April 2022, and ask, well, what did we know back then? Well, it already was established that COVID mortality rates were greater at older ages and in men. It was already established that broadly the reproductive number, meaning the number of people infected per infected case or from among the susceptible population, was roughly about 2, perhaps a little higher for COVID, the SARS-CoV-2 virus. But the case fatality rate was quite uncertain. There are some suggestions that it was a low case fatality rate, but real uncertainty. Now, other factors were also unclear. How many are undetected cases, whether asymptomatic infections can transmit, and how long does immunity last if once infection has occurred? And finally, whether the virus is seasonal. Now, we know a lot more since that time, and let me walk you through what that is. But it's important to understand, however, the immune response to SARS-CoV-2 to give you an understanding of what we're trying to measure. So this is the virus. It's called a coronavirus because it has these spikes, and once it gets into a human, it will trigger an innate immune response through dendritic cell activation. And then it also leads to adaptive immunity from different types of immunity. So there's cytokines to try to fight the infection, inflammatory factors, cytotrophic T cells that try to kill the infected cells, and also induction of antibodies. So that goes from a B cell triggers a plasma cell that then triggers the antibodies that attack the virus. And then eventually you get what are called memory T cells and memory B cells, meaning they have the original signal embedded and therefore can continue to fight the virus in subsequent months. And a broad schematic is that the infection starts off very quickly, leads to very high levels of virus or antigen if that's what is detected. The antibodies come up and are supposed to decay, and then somewhat later you get the memory cells and the specific T cells increasing, and these are persistent over time. In theory, they should persist over years. If we look closer at the antibody response, what we're interested in here is the same pattern. You see, if early on with symptoms, you'll have an infection, and the RNA in the virus, the RNA of the virus is detectable in blood samples. And if you're looking for the antigen, which is basically one of the proteins on the virus, not the actual RNA, which is inside the virus, then you can detect it, but at lower levels. And those wane as infection wanes. Now, this triggers the immune response, and there's different types of antibodies that are triggered. What we're mostly interested here is the IgG response, which goes up more slowly than the acute response, which is IgM, and in theory would wane over time. And it's very much dose dependent. If you have a very strong exposure, you should get higher levels of antibody than if you have mild. And what we're interested in a seroepidemiological study is having a sensitive enough assay and a specific enough so we can detect the assay or detect the antibodies well over several months. And so this is the principle on which we're drawing our studies. So what was the study that I've mentioned in Canada? Well, it's called the Action to Beat Coronavirus Study in Canada, or ABC. So what we did is very rapidly work with an online polling company that has 44,000 Canadians already enrolled from right across the country. We surveyed 19,000 for COVID symptoms and their willingness to do a home dried blood spot. We sent out kits to 14,000 people, 9,000 of them returned the samples, and then these were carefully handled and then underwent a highly sensitive assay to IgG on the spike protein, which I'll describe in a little bit more detail later. We then returned the results to the participants and asked them if we could resurvey them in January, and 8,000 of the 9,000 have agreed to be resurveyed. We examined the mortality rates from the overall Canadian mortality statistics to get infection fatality rates. But since the survey did not survey nursing home residents for serologic evidence, we used an indirect method based on mortality to calculate the nursing home prevalence of infection. So the procedures are very simple. This is all done at home. It involves sending a package to everyone. They do a 8-minute online poll about symptoms and risk factors. And then we gave them these lancets where they did a very safe, simple home dried blood spot. It takes less than 10 minutes. They let it dry for 2 hours, and then they mail it using a dual sealed envelope safely to a central lab. And then we do central antibody testing. The timing of the study was deliberately done as early as possible, before we had any money or any organizational capacity. We just started it. We discussed it on April the 12th, and we started the survey or started the collection by May the 12th. And that was good timing because most of the collection occurred between June 9th and July 9th, or the samples were sent out in that time, and the samples were returned between June to mid-August. And if you look at an online survey that was previously done, it showed about 8% of Canadians, adults, reported COVID symptoms. And the bulk of that was in March. So the greatest proportion of symptoms recorded in March, some in April, fewer in May. Of the national testing, that increased very few testing in March, but a greater proportion in April and more in May. And the deaths, of course, started to increase in May. So our timing, given what we know about durability of antibody response, was reasonable, that we think we've caught the first viral wave. So what are the results from Canada? Well, 9,000 of the 19,000 who provided dried blood spots, we found that 1.7% of them had what we define as definite antibodies to IgG, and this is using a higher specificity cutoff. 3.5% had definite or possible antibodies, using a higher sensitivity result. So overall, up to 1.1 million, between 0.5 to 1.1 million Canadians were infected, half of whom were below age 40. In a subset of the study, we examined seroprevalence in phase 2 in a subset of a higher risk areas, which was done in late August and September, and that had higher seroprevalence, and that characterizes the beginning of the second viral wave that Canada is still in the midst of. So what are some of the results? Well, of course, our goal here was to try to get a representative snapshot of the country, meaning we wanted the profile to look like Canada. So one of the starting points was to ask, how was our survey sample compared to the census? And we were broadly geographically representative, of course, and age representative, but whereas the census finds roughly 46% of Canadians had some college or less, in our sample, that was only 24%. So we did under-recruit the lower education groups. Hence, all the analysis is adjusted for education differences. On other variables, however, we had pretty good representativeness. So visible minority, we were close, 22%. In the census, 15%. We had a greater proportion of Indigenous. And in terms of health factors or health behaviors, we were actually quite similar to the national data on smoking, obesity, diabetes, hypertension. So we think it's a reasonably representative sample. So the results here, and I'd ask you to focus on the definite result, meaning the higher specificity result, was that, first of all, very small differences by education level in the infection, or by visible minority, indigenous, or any of the risk factors. Slightly lower for diabetes, but not significantly so. So there's very much a consistency across these education and risk groups. By contrast, when we look at representative of the age distribution, the age distribution was deliberately older because we sought to recruit older adults. So it's not representative, but it is indicative. And here you see that at ages 18 to 39, they had the highest prevalence, and generally prevalence dropped to the lowest at ages 70 or higher. Male and females were similar. Ontario, the province in which I live, had the highest prevalence, followed by Quebec, and the lowest was mostly in British Columbia, which includes some Yukon, of 0.9%. These are reasonably small sample sizes of how many were positive, so of course these confidence intervals overlap. When we examined the prevalence, seroprevalence by COVID symptoms positivity, and COVID symptom we defined as a combination of a fever or fever with hallucinations, difficulty breathing, dry cough, loss of smell, or COVID toe, the most important association was those that had COVID symptoms. So there was a strong correlation with COVID symptoms and seropositivity, and particularly those that had COVID symptoms in March had the highest seropositivity. In terms of, we also asked whether others in the household had it and whether the respondent or anyone else had it showed similar increases in seroprevalence. So this summarizes the results for COVID symptoms, which we think is a valid indicator in the clear diamond, and IgG antibody in the black square. So using youngest ages as the reference group, generally there's a downward attenuation of both symptoms and antibodies. And just remember this because it'll be very different when we come to India. Household size suggested that actually multi-person households were at lower risk. Again, very different than what we'll show in India. And this might be because single-person households were at increased risk of exposure. No differences in sex. And as I've said, symptoms in March, particularly COVID symptoms, were the most predictive of seropositivity. We were then looking at, well, what are the differences in the probability of having a COVID symptom versus not, and in terms of seropositivity. So it's a very similar pattern for province-wide. Provinces other than Ontario had lower COVID symptoms and also significantly lower COVID seropositivity. Visible minorities, ethnic groups, indigenous ethnicities, smokers, diabetics, and hypertensives had all greater symptomatology of COVID, significantly greater than 1, but the seropositivity was not greatly different. So they were predictive of symptoms, but not of seropositivity. We then examined asymptomatic infections. These are people who reported who were positive on either the sensitive or the specific cutoffs, and what was, but did not report any symptoms. And this was about 25%. And what was noted here is that in both cutoffs, the definites and the positives, there was an upward trend that the asymptomatic proportions were greater at older ages. So although fewer people are infected at older ages, a greater proportion of them are asymptomatic. And that actually might be important to help explain nursing home transmission, which I will come to in a second. So as one of the important things to note in any sero survey is how good are the assays, because this is really quite key. So the assay that we've used is developed by the National Research Council, is deemed to be reasonably highly sensitive and specific, but it still will have false positives, particularly at lower prevalence like we have. So therefore, dual testing is more specific, and we're going back and now testing with another assay. Comparison with other results is not yet possible because standardization of assays across different studies have not been done. And in the current round, what we will do is use 3 assays: the spike protein, which are used in round 1, N, and RBD. And that improves the specificity, but also enables us to determine vaccine versus naturally acquired immunity. So let me walk you through how that works. So back to the virus. This is the virus with the RNA inside, and this is the N sets of antigens that are inside. And then these are N proteins that are inside, and then this is the whole virus. And on the spike protein, there is several domains. This is the S, the main spike protein, but on top of it is what's called the receptor binding domain. And think of this like a zipper that becomes vertical and then is used to go into the cell. So the assays that have been developed have been targeted to the RBD, the spike, or the N. And the N is most important in clinical studies because it has the highest response and is able to measure neutralization. So, and this also then is how the vaccines have been developed. So what it means is by looking at a combination of these, you can distinguish naturally induced infections, which would be not without vaccine, not from vaccines, but from the virus itself, because you'd have both a response to RBD and S and to the N. Whereas for vaccine-induced immunity, depending on the vaccine, you would only get a response to the RBD or the S, but not to the N. So for example, the Oxford-Zeneca targets the full-length S virus here. So we should get results on S, but there might be some cross-reactivity with the RBD. And that's very relevant to India. In Canada, we're currently using the Pfizer and Moderna, which are to the S2 spike, S2 protein, and then the new Novavax will use the spike protein. So again, that'll target the S. So these vaccines should all show up as S positive or perhaps RBD positive, but not N positive. Now, in contrast, the Indian vaccine is a whole inactivated, and that would lead to a reaction of all 3. And therefore, currently you cannot distinguish natural from acquired infection for that vaccine. The other vaccines that are being proposed are also, however, more focused on the receptor binding domain. So this does allow a way to monitor the pandemic. Let me turn to mortality in the next part of the talk. So one of the things we've learned is an extraordinary variation in death rates from COVID across countries and over time. So compare Germany, which is down at the bottom, and Canada here. So in August, when we were doing this review, we noted that Canada had substantially higher death rates than Germany, attributed to Germany's good response. But you see over time what's happened, that in fact, German death rates have exceeded Canada, and that's from the second viral wave in particular. And what has been realized is very much that these phenomena are driven by nursing home populations. So if we consider Canada, France, and Belgium, what is shown here in the solid bars are the deaths. And I'm sorry, I've got it the other way around. Is it the cases? Yes, I'm sorry. The death rates are shown in the dotted, and the cases are shown in the vertical bars. And all three countries had two patterns. And you see much higher death rates early on than cases in all countries. And then in the second wave, cases and deaths are more comparable. This in part relates to changes in testing of who was allowed to be a case, but also it relates very much to nursing homes, which were a common source of infection in these populations. So in Canada, unfortunately, unlike in the UK, we don't report deaths by nursing home status and by age. So Patrick Brown and our team looked at the total population and did a very simple Poisson-Bayesian method to segregate the deaths that occur in long-term care homes by age into nursing home and non-nursing home deaths. Now, then we were able to figure out broadly what are the prevalences of infections at the different age groups. So from ages 20 to 39 to 70 or older, we used the direct ABC results for seroprevalence and the national deaths to calculate the infection fatality rate, both lower and upper, based upon the seroprevalence. And then for nursing homes, since we didn't have direct seroprevalence data, we used French nursing home infection fatality rates calculated from another study and applied that to this population, which is demographically similar, to calculate the mortality-based seroprevalence. And what you see here is some startling differences. So between, again, let's look at the infection fatality rate. Between ages 70 or older and 20 to 39, the infection fatality rate is got a 200-fold difference, just a huge difference in infection fatality rate. And in the mortality rate, even the nursing home population has 100 times the higher mortality rate than the comparable age group living outside of nursing homes of 70 or older. So huge variations in mortality rates by age and also in infection fatality rate. So overall, we estimate that using this combination between 1.7 to 3.5, and this is then the number between 5.5 to 1.1 million. Now, this table is also helpful to address some of the concerns or some of the logic that's been said. Well, why don't you just let infection run away and we'll protect the elderly and in nursing homes? Now, first of all, that's not possible because the nursing homes are connected to the same networks that would lead to infection in the community. And even if you did, you can do a quick calculation and say, well, if you took the lowest infection fatality rate and multiplied it by the Canadian population and said, what if infections were just to be continue as unchecked? That would lead to not 9,000 deaths that we had, but something like 45 to 100,000 deaths. So clearly this idea of trying to protect the elderly and do herd immunity is really not a very well conceived one. So what are the next steps on this study? Well, as mentioned, we're studying the next viral wave or the current viral wave. And this has already started and we'll be able to determine incidence of infection. In a sub-study, we will be pursuing the markers of cellular immunity that I showed you earlier, trying to get particularly T cells through some remote collection to be able to examine whether other types of immunity are important. And then the plan is to have this as an ongoing platform as vaccines expand to be able to resample the population, study antibody decay, and then we'll also be looking at relative decline in neutralizing antibodies. So the goal is to inform national strategies. But we've also showed that we can establish large-scale research using this very simple, low-cost, home-based platform. Let me turn to India as a comparison, and the results for India are strikingly different. So what we did here is we worked to focus on the urban cities of India, roughly 18 cities that have 110 million population. And that was because that's where COVID deaths are mostly reported. And that's where infection rates are supposed to be higher. And then we combined the collection of the ongoing case and mortality data with seroprevalence data run by ThyroCare laboratories, who have a national network of over 2,000 self-referred patients, 2,000 labs and close to 500,000 self-referred patients went to these labs, paid between 700 to 1,000 rupees for testing. And they were tested with two reputable assays, the Abbott or Roche IgG assays, mostly with the Roche, but the results were comparable with either. And this is the geographic distribution of the sampling site. So it does broadly geographically represent India. So we looked at these data and we conducted some Bayesian geospatial models to look at the trends in seropositivity cases and deaths. So this summarizes the results that across the 18 cities, so you see wide variation, and the size of the pink circle represents the number of cases that were detected. And of course, Mumbai, Delhi were the most affected, along with Bangalore and Kolkata, because they're the largest cities. So overall, in India, there's been 10.7 million confirmed cases. So that's 1 in 10 of global cases, but only 150,000 deaths, which is 1 in 14 of global deaths. And what we found here is, based on the mortality data, estimating seroprevalence, we find between 40 to 50% of the urban populations were infected as of December 31st. And this characterizes the serologic patterns, so from that self-referred population. And unlike in Canada, where I showed you it was generally declining with age, in India you see an M-shaped pattern. So it goes up in the younger adolescents, 10 to 14, comes down at the lowest to around age 20, and then steadily rises with a later peak in males than in females. And that's very much a pattern suggestive of household transmission. The incidence, which is the daily count of the new cases in both sexes, peaked in December and has continued to fall since. When we look at the mortality-based estimates of seroprevalence across the different countries based upon published infection fatality rates, and we see a huge variation. So Pune might have between 70 or 80% of its population infected, according to the mortality data. And Ghaziabad, by contrast, has 3% of the population infected. But in large part, this reflects differences in actual mortality. In the case of Ghaziabad, they're missing a fair number of deaths. So they're right next to Delhi. So the proper comparison is you'd expect their mortality to be closer to Delhi. And broadly, this variation across the 18 states or 18 cities is very reflective of the changes that occurred in the case rates per population. So this is shown here. And in limited settings, there have been serosurveys done in non-self-referred populations, in generally more representative populations. Broadly, you see that these are similar patterns. So Delhi just released a serosurvey that says about 56% of its adults were infected, and that's broadly in the range of what we estimate for mortality-based prevalence. Now, in terms of the time course, this is well known that COVID cases and deaths peaked in September and have come down substantially since. But that is a national profile and hides a fair amount of heterogeneity at the city level. So in Delhi, for example, there were 2 peaks of deaths, one in June and another in November. By contrast, in Pune, there was one big peak in August. And in Chennai, the big peak was in July. And in both these settings, you could say there might have been a second smaller peak. This is the shoulder that you see either in October, November, or in October here in Chennai. So this suggestion that the national profile shows going up and down is going to be the course for other places is not certainly true. Look at the remarkable two peaks in India or in Delhi. And it might well be that as we get into the warmer months or the hot months of March or of May in particular, when people are crowding indoors to escape the heat, particularly in North India, you might have increased transmission and another peak. So the suggestion that India has escaped the pandemic is probably not true. What is assuring, however, is the concerns about what was driving the pandemic are mostly not true. One of the papers that came out says, well, is air pollution. This is particulate matter in satellite measures, exposures driving the epidemic. And there was very little difference in particulate matter measured in 2015 or 2017, excuse me, predicting either the seropositivity or the cases or the deaths. Very little association. And similarly, migration had a very little impact. Solid fuel use was protective of cases and deaths, but not of seropositivity. And a young population was also protected of cases and deaths, but not of seropositivity. So a young population is understandable. That just might mean you have fewer susceptible older people. Solid fuel use is not suggesting that this is predictive, but these are more isolated rural areas within the country that have less connections. So this is a marker for connectivity. It's not a marker for the actual solid fuel use in the home. When we examine in a Bayesian model, what are the differences or the predicted seropositivity, you see extraordinary variation and hotspots. So you see it lights up in Coimbatore and in Nagpur and different parts of the country. And this suggests variation that needs to be understood. It also suggests, unfortunately, that the Indian Council of Medical Research survey that was recently published and reports 21% probably has the wrong results. Why? Well, they based their analysis on roughly they said they sampled about 700 areas of the country 70 districts of the country out of the 700. But the initial stratification they did was trying to stratify high, low areas. But it's a simple methodological issue. If you're not able to have multiple strata that take care of the heterogeneity, you will underestimate seroprevalence. And unfortunately, the ICMR survey design has maintained that design where they're sampling based on initial strata, and the initial strata don't capture the true heterogeneity of infection. So it will be an underestimate of infection. So what are the implications for vaccines as I wrap up? Well, first, every Canadian will pretty much need a vaccine, and nursing homes are the priority. There's a need to monitor natural and acquired immunity, and we need to do a much better job of reporting nursing home deaths faster. In India, it is true there is high infection rates, but probably the need is to vaccinate still. It's not the case that we can assume the natural infection is going to give us long-term immunity. It might well be possible to do operational research, particularly since the phase 3 trials were so truncated, in which I think a reasonable strategy would be to get as many of the Indian population with at least one dose of the AstraZeneca product in particular, because that's focuses on the spike protein. And then this kind of serosurvey that I mentioned, where you go and measure differences between the natural and innate response, would give you a sense whether, given high levels of background infection, does a single dose suffice in terms of providing protection. There's an urgent need to detect variants, particularly the P1 variant from Brazil, because that seems to escape information. And then, of course, there's better mortality information. And the key here is that what is needed is all urban areas of India should be releasing daily, weekly totals and the cause of death. That the government's been hesitant to release these data, but they're actually quite crucial to monitoring the trends. Now, what our study has commented on are urban deaths and urban infections. We really don't know much about rural areas, simply because the mortality is not well documented there. And we've urged the Registrar General to restart the Million Death Study, in which teams would go out to randomly selected areas, do verbal autopsies, and try to get information. And there might be other strategies like testing the dead in mortuaries. So let me conclude again with the key results. So in Canada, we had low prevalence in round one and low infection mortality rates. But we had a disaster in our nursing homes in that we had large numbers infected, and they accounted for 80% of the deaths. In the current viral wave, nursing home continues to be roughly 2/3 of the deaths that are occurring. In India, it's a very different pattern. Very high levels of infection have probably occurred in the cities, peaking in early December, but with low death rates. And in all settings, there's ongoing epidemiological investigation needed. So this is on behalf of a wide group of our investigators from the ABC study and from the GCAM. And you can find the information at cghr.org.covid. I'm happy to take some questions, or if you'd like, I have an interesting astronomical short presentation that we can turn to. So I'll turn it back over to our host.
Thank you very much, Professor Jha, for a very illuminating talk. So I will start with a couple of questions that I have, and then I'll turn it over to the others. So in one of the plots that you have shown in India, there are, of course, more cases in older people, and there are cases in a smaller number of cases in younger people, but there appeared to be a dip at around 20 years old, around that range. So do we understand the reason for that?
Well, I think the major explanation is it's around 20 to 24, and that's the most likely time that young adults are out of the house. So I think what's the major explanation is widespread household transmission. In younger kids, they will get infection with very little symptoms. In fact, what is also seems to be unique about the Indian patterns is you have, from the serosurveys, a large proportion are asymptomatic. Remember I said in Canada about 25% were asymptomatic. The serosurveys seem to suggest that upwards of 60-70% might be asymptomatic. So I think that's the explanation. You've got household transmission, and the lowest peak are in those that are out of the house.
Okay, thanks. And you also indicated that there is a wide difference in the prevalence in different parts of India. And even for places like, let's say, comparing Ghaziabad and Delhi, as you indicated, although they are geographically quite close, the prevalence appears to be quite different. Maybe like you mentioned, because some cases were missed in Ghaziabad, but are there some other reasons that you feel there might be there for the difference in the prevalence?
Yeah, we don't really know. I think what we did look at is because these prevalence estimates are derived from mortality, and we're assuming that the infection fatality rate does not vary so much across the cities, which it shouldn't. because it's similar demographic and population structure generally, then in some of the places, like in Ghaziabad, we contribute the low prevalence to low mortality, but that's under registration of deaths. In other, like in Pune, they've got a pretty good death registration system, so they're not missing any COVID deaths, whereas in Ghaziabad they are. Delhi is somewhere in between. So that's some of the difference. But the other difference is we don't quite know. They might well reflect different transmission dynamics. Particularly, you saw in Delhi, there were 2 peaks, and in Chennai, there was only 1 peak. I didn't show you the graph for Vizag, but Vizag really quickly shot up in June, July, and came down and has stayed low since. So we don't really understand the reasons for this heterogeneity in the spread. We need to take into account that there probably are undetermined factors that are heterogeneity and susceptibility. The evidence suggests, particularly with the low mortality rate in India and the low infection fatality rate, that it's very unlikely that everyone is susceptible, or even those that are susceptible might develop some generally mild infection. And that's quite important. That's globally important to try to figure out why there's been such low levels of mortality among Indians, what biologic factors might be behind that. What it would need is a study very carefully of not just antibody responses, but also T-cell responses. And we'd also have to look at what are the other correlates of protection in people who are exposed but not getting infected, or exposed and get very mild symptomatology. I think it does point to other infections that were circulating as the most plausible explanation for these variations. The younger age distribution of India is part of it, but the analysis that we've done on the mortality prevalence adjusts for the lower age distribution of India. So it's not biased by the lower age distribution. So there's just a lot more we don't know about the transmission and the susceptibility in the hosts of the Indian population.
Okay, thank you. There are several questions on YouTube as well, but I will turn it over to the FRP faculty who are on Zoom. And anybody can unmute yourself and please ask Professor Jha any question that you may have.
Yeah, so I would like to ask, so initially when we were talking, okay, this is Dr. Harish Gupta from Osmania University. So initially there was a lot of discussion about vaccine, because vaccination in India is a regular stuff. And there was a lot of discussion that because we Indian gets BCG and many different kind of vaccinations. So do you see, is there any link between vaccination in India in early age and then low mortality? Or
that's the speculated hypotheses, is both BCG and polio vaccines. We're looking into that with the Million Death Study data, and there's some broad ecologic evidence that suggests so. But it could be one of the reasons, and BCG as an exposure might be a marker for broad exposure to other infectious diseases. So we really don't know. Now, if you go further from India and go out to Vietnam or Thailand, and they've had extraordinary few deaths from SARS-CoV-2. And it's not because of a reporting system is poor. In both countries, the reporting system is actually quite reasonable. And the most plausible explanations in those settings are that the seasonal coronaviruses that are bat-based, bat species of seasonal coronaviruses, circulate quite widely in those settings. So there might well be some cross-immunity, cross-protection. So what it needs is serologic studies in those populations. And I think within India, within the big diversity, to try to figure out what are the correlates of protection that are occurring to explain the low mortality rate. infection in India has been, but by any means, it's been a disaster because it got really widespread infection. So I think most of the control measures did not really work well, despite the claims that they did. But India's been spared because of a very low infection fatality rate. And the reasons for that really need to be understood. And that's globally relevant. It's relevant to understanding, how would vaccines work, or how would they reduce the consequences of SARS-CoV-2 in different populations.
So, okay, you also pointed out that during summer month, once we will be at home due to heat, so there are more chances of being infected. So do you really, because I'm little, now I'm really thinking, because now people become total careless here. Okay,
Yeah.
you don't even find mask and much more protection, because previously for last few months, we were so much careful. Okay,
Yeah.
but now that fear is gone from out of mind of the people. So really, is there any chance of going in that direction?
I think so. I mean, you look at what happened in Delhi, and they had two distinct waves. And if the conditions reoccur there, if you've got indoor crowding without masks, those are the perfect conditions for transmission. So, and the virus certainly is not eliminated in the community, even with the low levels of infection. And they're still, despite high seroprevalence, there's probably still high levels of susceptible population. The other unknown is whether any mutations are introduced in the Indian setting. In Manaus in Brazil, in the Amazon, they had 80% reported prevalence in the population, and they were saying, "Oh, okay, we're all infected. We're not going to get reinfected." But in fact, they've had another wave, which is causing a big increase in deaths. Now, that's a context with very high death rates, so they're seeing a lot of deaths. But the explanation for why they were reinfected could be either really two. One is the antibodies from a natural infection really wane quickly. And the second is that the mutant, the mutation, the P1 mutation is the dominant source of the new infections. And that means everyone is susceptible if you have not had that original infection. So there's nothing like, oh, we're out of the woods yet for India.
Okay, thanks. So one last question. So now we have already started vaccination, and given the quantum of population in India, right? And the kind of vaccination is already started, but still we don't see much progress in that one. Okay, so to vaccinate entire population, probably it will take several years. So do you think by that time COVID will go away automatically, or it is going to be there and everyone need to be vaccinated?
We don't know. On one hand, the evolutionary biology would say that the virus has an advantage in basically mutating to be a very innocuous seasonal cold virus, and that's what would give its most evolutionary advantage. On the other hand, that's in the absence of selection pressure. Vaccines might well exert some selection pressure to select out the more virulent strains. And we just don't know whether this is going to be a seasonal phenomenon or it's like SARS-CoV-1, it'll go away and it won't come back. We just don't know at this point.
Okay, thanks a lot.
Anybody else has a question, or there is a question I can see from Shankar, and he's saying, thank you for the interesting talk. He's saying that is the spike protein, is it man-made or is it of natural origin?
The spike protein is it's derived from the structure of the actual SARS-CoV-1. And what the National Research Council did is they took that and they manufactured a target antigen for ELISAs based upon the best reconstruction of that they could do. So yes, it's basically, it's derived from nature, but with some tweaks to try to increase its responsiveness in antibody assays.
Okay. There's a question from a Canadian participant that is asking about what is the difference between the Pfizer, the Moderna, and the AstraZeneca vaccines, and which one would be better in the Canadian context?
Yeah, that's a good question. I think the Pfizer and Moderna are both messenger RNA viruses. The AstraZeneca is an adenovirus vector. All of them target the S1, more or less the S1 spike protein. They are all good vaccines. I would take any of them. It just happens that the one that I got as a healthcare worker was the Pfizer, but I would not hesitate at all to take the AstraZeneca vaccine, or in fact, the Russian Sputnik vaccine also is a very good vaccine. They have been produced by a very credible lab, and they published their results with high scientific scrutiny and promised to make all of their data from that study available, individual level data. So that inspires confidence that it's actually a trustworthy product. And I think that's the appropriate standard of judging vaccines, is to listen to what experts believe is the scientific scrutiny for those. The differences between a 90% efficacy and a 70% efficacy at the population level are trivial. If you got 70% efficacy vaccine widely spread, and the AstraZeneca vaccine and the Sputnik are more practicable because the Pfizer and Moderna require a much greater level of refrigeration or deep freezing than does the AstraZeneca. So those are all the considerations. I think they're all remarkably effective vaccines done quickly. They all need to be rolled out quickly.
Sushil Chauhan has a question. Sushil, please go ahead.
Okay, thank you. So basically I have two questions. So the first question is, once one get infected with this virus, do we have any idea how long the immunity is there, for a year, for a few months, or 2 years? And the second question is, if the immunity remains there for 1 or 2 years, do we really expect to see another peak in India, especially in urban areas? Because as your slide shows, that 40 to 50% have already got infected, and the immunity is going to be there for another 1 or 2 years.
We don't know enough because the virus has only been around or we've been studying it only for less than a year. A study out of Oxford among healthcare workers showed that in those that had natural infection, then their ability to ward off new infections was pretty high, almost the same level of efficacy as a vaccine, up to 32 weeks after the infection. So we think for 8-9 months, the vaccine does, so the natural immunity does give some protection, but that's against reinfection. In terms of picking up asymptomatic infections, it is not nearly, the natural infections aren't nearly as effective. Will India get whacked again? Well, I think we really have to be prudent because there's at least 3 big unknowns. One is, do the antibody levels really stay that high in the Indian population over time? Healthcare workers in the UK, by some measure, if you think who got exposed in the UK among healthcare workers, they probably got a heavy dose of the virus. So in fact, they might have monitored the very high antibody levels, which will stay over time. If in India, the suggestion is that it appears to be that most people are getting very low levels of viral hits and modest asymptomatic infections, then those antibodies might in fact wane faster. And the third caution is just to look at what happened in Manaus, Brazil, where they reported 80% prevalence in the Amazonas. And 3 months later, they've had another big spike in deaths. And that appears to be from a combination of waning antibodies plus this the mutations. The P1 mutation is really probably the main explanation. And if that occurs in India, that would be a disaster, because that's also affiliated with a higher death rate. So there's a great amount of caution before suggesting that India won't get hit again. It might well do.
And
Yeah.
what you
Go ahead.
think about the Europe, means how it's gonna, what kind of trend we will see in Europe, especially kind of the weather or the vaccination, and what we expect in Europe, how things will move on from.
Oh, in Europe, yes. Well, I think they're very similar to the North America setting. There's in between Canada and the US. The US had uncontrolled transmission pretty much in large parts. Canada, we managed to keep the infection levels low. Europe is somewhere in between, but they will be much similar to the Canadian profile. They really will need widespread vaccination to come in to have any hope to be able to really get ahead of the epidemic.
Professor Jha, there are a few more questions. I hope you don't mind.
Sure.
S. Ganeshan is asking that you mentioned that the ICMR study does not take into the inference model, the spatial heterogeneity into account, and may underestimate the effect. So why is there underestimation and not overestimation?
The way they did the study is they originally sampled in April by looking at 4 strata based on cases. So that was the cases reported at that time. So, but the 4 strata are probably insufficient to deal with the real heterogeneity. And then when you look at the results from the first serosurvey and ask, well, as you would expect, then the places that were considered high risk should have higher positivity, but in fact they didn't. So it suggested that that initial criteria for selecting or stratifying was flawed. And now they've kept that same study design to keep going over it. So I think it's much more likely that they're underestimating than overestimating the prevalence.
One question from Arshavin. So he's asking, what is the possibility of a second wave in India, and how many cases can we expect to have at the end of this year?
Well, I don't know. I never predict the number of cases, but Delhi has already had a second wave. And it's really important to note there was a June wave and a November wave. And other settings might have had a smaller second peak, at least in terms of mortality. Remember, when you do these studies, you cannot rely just on cases, because cases are quite biased as to who gets tested and the changes in testing over time. The most reliable data would be to have good death data. So that does mean that the urban areas do need to substantially improve their death reporting and the timeliness of reporting those data. I think releasing weekly all-cause mortality counts for each of these cities would be a good start. And I hope you all write to your municipal corporations and ask them to do so, because it's a very simple thing to do. Just put in the newspaper the weekly death counts from all causes, and then you can track what's happening overall to the pandemic. But we don't know whether there will be other waves. I think you really have to be diligent. And I am concerned that particularly come the hottest months, when you have more indoor crowding, and as your colleague mentioned, people relax and aren't using masks or physical distancing in any way, then we will get a resurgence.
Last 2 questions. So Agastya is asking, has there been any research done to identify the most common reason for COVID transmission in Canada?
The virus has it's a really terrifically sticky, well-transmitted virus. I mean, its evolutionary features are quite admirable, that it's quite able to adapt and transmit. The biggest predictors that have consistently been identified as not the milieu for transmission are closed indoor spaces with poor ventilation and usually somewhat colder temperatures. So, but that's basically like the room temperature that I'm at around 20 degrees or so. If you go slightly colder, like if you go to some of the transmission that occurred in meat packing industries, because their rooms are around 7 or 8 degrees Celsius. So that's also an efficient way of transmission. If you go very high temperatures, then there appears to be less transmission. But the big thing is closed indoor spaces with little ventilation are where most transmissions of the virus will occur.
Okay. The last question now, there are two questions which are related, so I'll ask them together. So Kishore Kumhar is asking, after we take the vaccine, how long will we be immune? And Swagat Mohapatra is asking that once we are vaccinated, how long would we have to follow the precautions in terms of wearing masks and so on? So how long will this continue?
Yeah, we don't know how long the vaccine will induce immunity. That's quite true. Now, in terms of thinking about returning to close to normal life, well, we have to get the levels of the virus down in the community to such low levels that if it does cause infection, it causes very mild infection with little onward transmission. So that's still some time away. I think we'll have to do at least masks for quite a while. But then again, masks are very commonly used in East Asia, in Japan and others, with not too much of a disruption in normal life. But I think the key is to use all the strategies that are possible to drive the community transmission levels down low. And that will also depend on much improved testing. We've talked mostly about vaccines, but I do want to emphasize that rapid testing and isolation is a very effective strategy. If we didn't have a vaccine, but we had something like 100 billion tests available for the world. So every person could test themselves, let's say, every month or every week. Then effectively you could shut down the transmission. If you tested weekly and you stayed at home if you were positive for 2 weeks, that would pretty much drive the transmission down low. So testing has to be a complementary strategy to what we've talked about. We didn't discuss it today, but it's a fair amount of time before we come back to normal, I think.
Thank you, Professor Jha, for this wonderful talk and patiently answering all our questions. All of you, thank you very much. And thanks to everyone for being here as well. So we will be back in March with the next lecture in this series, which will be announced shortly. And I wish everyone a good night and wish you a good day, Professor Jha.
Thanks very much. Bye-bye.
Yeah, bye.
So it's interesting, but